Okay, thank you so much. So Sandeep unfortunately wasn't able to connect to the conference, so I was not prepared for this presentation, but I know a lot of know part of the presentation, so I will try and do my best.
Sure.
Let me see. Okay, so it's about antihypertensive medication in COVID-19. And as I discussed earlier during this conference, the renin-angiotensin system is very important in the COVID-19 pandemic, and it has been a lot of debate about whether renin-angiotensin blocking agents could protect from deleterious effects of increased angiotensin II levels. And there were was a lot of research, especially about whether we should discontinue renin-angiotensin blocking agents because they might increase ACE2 levels and therefore could maybe increase the infectious rate of the virus, since the virus uses ACE2 to enter the host. And there were many observational studies done, and of these observations also meta-analysis that actually came to the conclusion that renin-angiotensin blocking agents show a neutral or maybe even a slightly beneficial effect when you have a COVID infection. But most of these studies used the combined ACE inhibition or ARB medication together, and they did not make a difference between the two. And besides of that, the hospitalized data, because these were observational studies from hospitalized patients with a COVID-19 infection, they could be biased because of discontinuation of antihypertensive medication at admission. And then you would wrongly assume that individuals using renin-angiotensin blocking agents at home and being admitted to the hospital and then maybe have severe disease or even die, that it might be due to these medications, but instead, since during the course of admission this medication is stopped, it might be due to the fact that these medications are stopped. And that was our main interest of this research. So we were interested in whether discontinuation, especially of angiotensin receptor blockers in hospitalized patients, would lead to a more severe COVID-19 outcome. So what we did is we conducted a large database observational study in which 10 hospitals participated, and there were more than 1,700 hospitalized SARS-CoV-2 patients in this database. And we also gathered personalized data on prescription of antihypertensive medication in the general population, so we could have an idea about the distribution of the different antihypertensive medications that are used in the general population in the Netherlands particularly. So what kind of definitions would we use? Well, the COVID-19 diagnosis was, most of them, I think it's almost 95%, had a positive SARS-CoV-2 PCR test. And if not, they should have a CONNET score of more than 5 on the CT scan, or the diagnosis of a COVID-19 disease. Severity of disease was defined as either mild disease, severe disease, or death. And mild disease were individuals who were hospitalized but did not have a low oxygen level, did not go to the ICU during admission, and did not die. And individuals defined as severe disease were those admitted to the ICU or individuals admitted to the wards but with a low arterial oxygen pressure below 80 millimeters of mercury. And the third group were individuals that in the course of admission died. For the definition, medication stop was the medication that was registered as at-home medication, but was not available in the records anymore when the individuals were admitted to the hospital. So we do not exactly know when the medication was stopped during admission, but at least it was registered that they used it at home, and it was registered that they did not use it anymore during the hospitalization. So what we do with the missing data, any individuals of which antihypertensive medication at home was missing were excluded. So only individuals of which we know which antihypertensive medication, whether they were using it and which one, were included in the study. And as I already mentioned, if there was missing data on antihypertensive medication, either at home or in the hospital, these individuals were excluded from the analysis. Also, we do not know when the medication was stopped. I already mentioned that. And any continuous variables for which we would use as confounding variables to adjust our analysis for, if they were missed, we imputed them via a multi-imputation method, and it was around 5 to 6% of missing variables. So then I come to the results. So our first question was whether ARB use in the general population would protect against the hospital admission, meaning that if you postulate that ARB medication is beneficial in treating a COVID infection, this would mean that the percentages of individuals admitted to the hospital would be lower on using an ARB than in the general population. You can make you can compare these two to one another, and this is what we did in the first step. So we compared the general population on the use of antihypertensive medication with the ones that were admitted to the hospital, and we did not really see large differences. So there are some differences in age. There were some differences in the amount of male gender that were in our database. But if you look at the at-home antihypertensive medication, there was no difference in ARB use in age inhibition, but there was an enrichment for beta blocker use, and there was an enrichment for diuretics. So individuals who are admitted to the hospital for a COVID infection are more often users of beta blockers and diuretics than what we would expect from the general population. And as expected, the comorbidities were also enriched in our hospitalized patients, but we actually already know that individuals with hypertension, diabetes, with a history of coronary artery disease, or with a history of heart failure are at risk for more severe COVID-19 disease. So this is our baseline characteristic of the individuals that are hospitalized, divided in groups of mild, severe disease or death. And then we can see, change this. Okay, sorry about that, but I have some error in my screen, but I cannot fix that. So there was a higher amount of individuals, the individuals severe disease and the individuals that died were often of older age, more often of male gender, and used more often antihypertensive medication. And then if we go to what kind of medication they were using at home, it was less often an angiotensin receptor blocker. So here you can see a relationship between the severity of disease and the percentage of individuals on an angiotensin receptor blocker. They were a little bit higher for an ACE inhibitor, and there were individuals with severe disease more often used a calcium channel blocker, and those were significant differences. And again, also for the comorbidities, we see that individuals who died were more often individuals with the specific comorbidities that I discussed before. So to conclude, is the use of ARB was significantly lower among patients who died compared to the one who developed mild disease. But the real question was whether the discontinuation of an ARB, whether that would lead to a more severe outcome. And for that matter, we did a logistic regression analysis, and we used various different models. So our model 1 is a univariate model, and then the model in model 2 was adjusted for age and sex, and then it was further adjusted for the Muse score. That's a kind of score of the severity of disease during admission, and for a low oxygen level, but then only in the group who died, because in the group with severe disease, this is actually the variable of definition. In model 4, we additionally adjusted for the amount of antihypertensive medication somebody is using, so whether it was 1, 2, or 3 or more. And in model 5, we also additionally adjusted for comorbidities. And as you can see, it really doesn't matter for what kind of variable you would adjust the data, because it keeps in the same direction and in the same amount. So the point estimate is around 2 for ARBs, so you have a 2 times increased risk for dying if you stop an ARB, and if you would stop an ACE inhibitor, you also have a 2 to 3 times higher risk of dying, and if you stop the beta blocker during admission, you have a 3-fold to 4-fold higher risk of dying. And this was not the case for the calcium channel blocker and the diuretics. So there was no, that actually means that it's really something to do with the medication, and not so that you're looking at severity of disease or anything, because then you would expect the same for calcium channel blockers and diuretics. So to conclude, the discontinuation of either an ARB, an ACE inhibitor, or a beta blocker during admission leads to a 2 to 4 times higher chance of dying from a COVID-19 infection. And this was actually regardless of age, sex, comorbidities, antihypertensive medication, and severity disease, such as the Muse score or a low oxygen level. Then we would ask ourselves whether there is a difference with respect to the potency of the ARB on the severity of outcome. As I previously mentioned, most of the Western countries prescribe low potency ARBs, such as losartan and valsartan, whereas there are much more better and higher potent ARBs, such as telmisartan and irbesartan, which have a much better AT1 receptor affinity and also a longer half-life. So we would expect also a more, a better outcome with these drugs. So what we did, how did we define high or low potency? Well, that's what's specified here. So we looked at the lipid solubility, we looked at the affinity of the AT1 receptor, we looked at the dissociation rates, the half-lives, whether it was an insurmountable antagonism or a competitive, and of course the half-life. And in that respect, we divided these ARBs in a group with a high potency, that was telmisartan and irbesartan, versus the rest, which is a low potency ARB. And if you would then look for the different percentages of these different potency ARBs among the different groups, like mild disease, severe disease, or death, for the low potency group, you would see an increase in the amount of low potency ARBs, while for the high potency ARB, you see a decrease in the amount of high potency ARB used within these groups. And this was tested for trend, but we did not find a significant. It was a borderline significance. Could be because we tested for trend with the general population, which kind of skews your analysis, since this is an extremely large group. So I would like to recalculate this, but probably it is due to lack of power that we just do not find a significant difference. But it's striking that in the low potency, you see an increasing trend, while in the high potency, you see a decreasing trend. So to conclude, individuals with a SARS-CoV-2 infection had an enrichment for comorbidities. The individuals who died of a SARS-CoV-2 infection had a lower percentage of ARB users, and discontinuation of ARB, ACE, and beta blockers during admission was associated with a higher chance of mortality of a SARS-CoV-2 infection. I would thank you for your for listening.